Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of the optometry field through dynamic insights, practical clinical tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in eye care. Our mission is clear: empower eye care providers with the knowledge and tools needed to provide exceptional patient care. At Advanced Patient Care, we are dedicated to elevating eye care one episode at a time.
I'm Dr. Zach Keenum. I'm an oculoplastic surgeon at Vance Thompson Vision in Sioux Falls, South Dakota. And I'm here with Dr. Risfet today, and we're going to talk about oculoplastic surgery, what it is, what it involves, what kind of surgeries we do. We're going to look at it from kind of the patient side of things. So what to expect as a patient, what to counsel patients on if you are an eye care provider, but maybe you don't provide oculoplastic surgery as a service. We're going to kind of go into all that so you get a really good grasp of just what the specialty is, who it's for, and how to kind of educate patients around it and some of the new things coming along in oculoplastic surgery.
I love that, Zach. And I'm Deb Risfit. I'm from Alexandria, Minnesota, Vance Thompson Vision. And I'm just so excited, Zach, just to have a conversation today about, something that we're super passionate about. Zach, there's a lot of people that don't know what the term oculoplastics entails. Can you kind of give a rundown of what the specialty involves? What
Yeah.
kind of surgeries are you doing every day? What kind of patients do you see?
Right. Yeah. So oculoplastic surgery is really just plastic surgery around the eye. So it essentially focuses on plastic surgery in this area. It does branch out into the face a little bit in some circumstances. And we'll also do things like orbital surgery, tear duct surgery, that kind of thing. But by and large, 85+% of what we're doing is eyelid surgery, both functional, meaning for helping patients function better in their daily lives, but also cosmetic and aesthetically in this area. And so we're primarily seeing patients that either have issues with their vision due to heavy upper eyelids, or the eyelids are rolling in or rolling out or causing them issues for some reason, in which case we may need to do reconstructive procedures. But a lot of what we do also is for aesthetics and cosmetics. So that side of oculoplastic surgery has seen a shift to the younger population, especially in recent years, and a lot of that probably owes to COVID and everybody getting on Zoom and seeing themselves in cameras that are facing back at them and seeing their eyes and that kind of thing. So that's most of what we do. But to go back a little bit, oculoplastic surgery is typically something that's done after ophthalmology training. So Deb, you and I are both ophthalmologists by training, and then we have kind of further pursued doing a little more in-depth work in just eyelid surgery. And so that's really what oculoplastic surgery is.
Yeah, and that's beautiful. And, a lot of people that come to us are referred in from their primary eye care provider. And so what are the things that we're looking for as, comprehensive ophthalmologists or in the optometric community to say, I think that this patient would be a good candidate for eyelid surgery?
Yeah, that's a good question. And this is something that I actually went through personally through training. So when we're in ophthalmology residency, a lot of times we're in these situations where patients have very significant eye pathology, a lot of really severe diabetic retinopathy and tractional retinal detachments, and, some really severe things that maybe you don't see as much in private practice anymore. But one of the things I realized was that we just weren't looking at patients' eyelids. We were really just trying to get to the heart of what was their really severe problem that was limiting their vision. And so it wasn't until I really got into fellowship that I learned to look at people from that way and look at their eyelids and their facial structure and actually all of it and how it works in harmony with their face. So that took, I would say, about 6 months to learn to see a patient in that way. And it was something that I really, really focused hard on. And during training, I watched the people that I trained with about how they looked at patients. And I would look at what surgeries they were signing up certain patients for. And one trick that I even found in training was I would go look and see, just based off a patient's photo, what I thought that they needed surgically. Then I would look in the notes and see what my attendings had decided they needed. And that helped train my brain. So before I get too much into all of that, is that kind of like, was that your experience as well, Deb, or?
Yeah, that's beautiful. And, I always tell patients and colleagues, some of it is a science and some of oculoplastics is an art. And that's why we love it. You and I, Zach, share a love for painting. We like to use our creativity. And so, that's really important, to look beyond, just the pathology of the globe. And, one thing I've found out, being a comprehensive, I focus on cataract, refractive cataract, glaucoma, and oculoplastics. And so what I'm seeing is that we see a lot of pathology of the lid from these other disease processes, whether it's from long-term glaucoma medications or if they've had multiple surgeries, they come in because the levator muscle is stretched. And so they get ptosis that we have to repair down the road. And
Mhm.
so, a lot of things that are done, just surgically in ophthalmology sometimes end with needing an oculoplastic specialist to really get them to see fully. Say cataract surgery, we're getting them to see better and more clearly, but guess what they're noticing? They're noticing that their side vision is gone from droopy eyelids. And so that's where, Dr. Keenum, you come in to really evaluate this patient. And one of the things that you brought up was, the change after COVID, we're going on Zoom and we're seeing our face in a different way. We're looking in the mirror differently than we used to. And so younger patients are starting to come in. So, is it too early to have, say, an eyelid procedure? And when does insurance kick in? So, when do we have a functional case where we need to remove droopy eyelid skin that insurance will pay for versus it being cosmetic?
Yeah, that's a good question. Yeah, it's something that people ask us every day, I think, when they come in, is my insurance going to cover this or not? And so there's tests that we can do in office that are relatively quick. We'll do visual field testing on patients to see if they qualify through insurance. So we'll have patients do visual field testing, then take their eyelids out of the way and see if their field of vision, their superior field of vision improves. And that can be an indicator to the insurance companies that by doing a surgery like a blepharoplasty or sometimes brow lift or ptosis surgery, that their vision will improve and therefore there is a functional reason to do the surgery. Some of the other things we look at are the distance between their line of sight or their central vision and their lid margin. These are some of the things that the insurance companies look at. And if patients aren't candidates, we're able to tell them that. A lot of times the surgery can still be helpful cosmetically, and so we can still offer that to patients. But that's kind of how we go about evaluating them and seeing if they're going to qualify. And it's not always something that you can just tell from looking, in your office, in your optometry clinic. So if you're not sure, you can send them and we can do the testing and let them know, and they'll know before surgery whether or not they're going to qualify, so there's no surprises.
And I love that. And I always like to follow, there's a dry eye paper put out by ASCRS that talks about look, lift, push, and pull. And I think that's brilliant for oculoplastics. You want to turn on the lights. You want to look at the patient's face, from the forehead down to the chin to kind of look at their anatomy and see, if they have changes, in their musculature, if they have changes in their bony structure, if they have changes, maybe in the way that, one side is versus the other. So I always like to kind of note some asymmetry. I also like to, kind of push on the eyelid to say, okay, a lot of these patients that we're doing eyelid surgery on have dry eye. And so we don't want to make their dry eye worse with doing any type of procedure. And so we're looking at the meibomian glands. We're making sure that they have enough tear film to really protect the cornea and the globe. Lift, there's not just droopy eyelid skin that we see. There's brow ptosis. There's muscle droop from maybe a chronic eye rubber or someone that's used contact lenses for a long time. And so that's where we're kind of pulling and lifting and trying to figure out, is it coming from just the excess eyelid skin, or do we need to address the brow? Do we need to address the muscle? Do we need to tighten the lid? And that's where pulling comes in. When we pull on the eyelid, it should snap back. And so we're assessing not only the upper lids, but we're looking at the lower lids, even if that's not their complaint, because a lot of these patients that come in have a poor snapback test, it's called, where you pull down on the eyelid and it doesn't resume correct anatomic position. And so those are patients that you also can address the lower lids at the same time as the uppers. And a lot of times, as you probe and ask questions, they do say, oh, yeah, I have tearing down my cheek all the time. Well, anatomically, their lid is probably not in the correct position. And so these are all things that we look at when we're evaluating patients. But, just to kind of note that, a lot of people don't realize how much it's impacting their lives. Would you agree with that, Zach?
Yeah, absolutely. And I think you bring up a good point that it is a multi-part problem, especially with the uppers and the droopiness. It's typically brow, lid position, and then skin, those three things. And so often we're looking at doing blepharoplasty combined with ptosis and sometimes combined with brow lifting. And I'll typically do all of that at once if needed. And the other part of it is that it's a dynamic system. So sometimes fixing one thing may worsen the others. So sometimes patients will have mild amounts of ptosis that if you correct it in office with phenylephrine or even mechanically with your finger, you can actually see their frontalis and brow drive decrease. And so it can be an indication that you're going to need to either add brow lifting into the surgery or maybe just forgo the ptosis surgery altogether if it's mild to begin with. So we're addressing all of these things with surgery often. It's not uncommon that I'm doing a blepharoplasty, ptosis, brow lift, and then, like you said, also addressing the lowers. So that poor snapback is pretty common in our older patient population, and you really do need a tight lower eyelid for the tear pump function of the lid to work. So the way that the tears move across the eye to the tear system is by having a tight lid that when you blink pushes the tears across and actually mechanically move them. And weak lower eyelids or ectropion or mild ectropion will make that such that it doesn't work. And one of the things that we'll also combine it with even our younger patient population, even with the mildest amounts of lower lid laxity, for things like lower blepharoplasty, I'll combine lower lid tightening. So I've been doing a lot of canthal suspension techniques and canthopexy techniques where we don't necessarily open up the lateral commissure completely, but things to tighten the lower eyelids with lower blepharoplasty to prevent what's probably the most dreaded complication of a lower blepharoplasty, which is lower lid retraction, where you get a pulling down of the lower lid or a rounding of the lateral canthal angle, where patients lose that almond shape or that nice, well-defined acute angle to their lateral canthus. And so I've been combining a lot of those techniques with the lower bleph patients as well.
Yeah, and that's beautiful.
Want more? Schedule your personalized mini fellowship at Vance Thompson Vision today. Immerse yourself in hands-on learning, gain insights from our experts, and take the next step toward excellence in eye care. Remember, the world of eye care is ever evolving, and so are we.